guys, this is going to be your live demo for your wound packing for this week, okay? So I have the mannequin here with an abdominal wound packing. You guys are used to just dressing like an incision line from year one. So now we have to talk about doing the sterile technique with a wound packing, okay? So I've sort of set it up just because I'm working with only one camera angle today. But let's talk about a few of the steps I would have done before even setting any of this up. So the first thing you would have had to do, or you would want to do, is check your physician's order. It's going to tell you what type of dressing you need to do on your patient. It's going to also tell you the frequency in which you need to do your dressing change. So if it's twice a day, every 2 days, every 3 days, you'll know the frequency, okay? You're going to have to check your nursing notes, your documentation, to check and see when the last wound was changed and if it's due to be changed today. We still check our wounds in between the frequency of dressing changes just to make sure it doesn't need to be changed in between those dates, and make sure that there's no shadowing and heavy drainage seeping through the actual wound itself and the dressing that's covering it. But again, you want to just know what those orders are, okay? I also check my nursing notes to see how the patient tolerated the procedure the last time, what equipment and how much of it they needed. It'll help you help guide you go gather your equipment when it's your turn to do the dressing change. And if they didn't tolerate the procedure well, that's when you can decide to go ahead and administer an analgesic, then wait 30 minutes and then come back and do your dressing then so your patient's more comfortable during the procedure. So I would have considered doing all of that. I also would have prepped my environment. So we need to make the environment as sterile as possible. So we need to close windows. If the window's open, we need to turn off fans. We need to remove fruit and flowers. Extra traffic in the room usually isn't encouraged. One person watching is fine, but otherwise we would get them to step out for the duration of our dressing change. I'd also want to make sure that I sanitize my tabletop. A urinal could have been sitting on here. The patient could have just been eating or they're about to eat. We have a bunch of dressing supplies on here. So just make sure you're cleaning your environment before you're putting on all of your new dressing supplies. I already collected all of my equipment, so this just isn't sitting in the patient's room. I would have had to go into the clean utility room and gather their supplies based on my doctor's order and based on my nursing notes. So here I'm using a disposable dressing tray. It has 2x2s and 4x4s sterilely packaged in here, and I know the dressing that I'm doing. So I know that I don't need any additional 2x2s and 4x4s. If you do, make sure you're grabbing the individual sterile ones, not the ones that come in the large bulk packaging. Those aren't considered sterile, so make sure you're grabbing the right ones. I have a garbage bag. You can use this one and just tape it to a side rail, but you can also use the garbage in the actual patient's room as well. Just consider the height of your garbage. If you're somebody who runs the risk of always lowering your hand to drop it into the garbage, then you're going to break sterility. So set yourself up for success. If you want, you can tape it here or on the side rail down here, depending on how you set up your table, and I'll talk about that in a minute. The other thing I have is I know, based on the nursing notes, that it's covered with an abdominal pad, okay? I have sterile scissors. I have Conform. Commonly it's PHMB, I believe it's called in the hospital, but it's just the item that we're going to be packing the actual wound with, and I have to cut it because I know that it's not going to take the whole roll. Okay, I have some sterile packaged cotton tip applicators. We use these to measure a wound length, width, and depth, but we also use them to detect any undermine and tunneling in the wound as well. So you need those. We have sodium chloride, so your saline, that we're going to use to clean. I have tape to secure the wound. There are different kinds of tape. It always tells you on the inside of the roll what kind it is. This is transport tape, so you're going to have to know what they've used previously. I have sterile gloves and a measuring guide. Okay, so this needs to always be sort of visible, so I keep it off to the side. The other thing that I forgot to grab is 2 pairs of non-sterile gloves, so I'm just going to go to the edge of the room and grab those. So you'll see that I have everything sort of off to this side, my sterile dressing closest to the patient. You'll also see the way that I've set up is what's called the Sterile Triangle, which shouldn't be new to you guys. Okay, so my table is pointing towards the wound. If it was a foot dressing, I would move my table down and have it facing towards that. But it's an abdominal wound, so I want it nice and close. Remember rules of sterility, you can't turn your back to your actual dressing tray, your actual table. So I set myself up so I'm not ever really having to fully turn. I do have hand sanitizer here, but I'm still going to be able to wash my hands without fully turning my back to my table. I also have it at a good working height. Again, anything below your waist, if it drops, is considered unsterile. So bring everything up, and I've already raised the bed to a good working height. Okay, I am going to wash my hands to start. Okay, check your patient identifiers, explain the procedure to your patient. You could have done that beforehand whenever you were offering an analgesic, okay, but I didn't mention it. So I'm going to just make sure that I have the right patient, I'm doing the right dressing on the right person. I'm then just going to expose the area that I need to, okay. And make sure your patient is comfortable throughout this procedure. Okay, I'm just going to set up my garbage. If the previous nursing note said that this dressing was heavily saturated with drainage and there was a foul odor and we were maybe treating an infection, I wouldn't put my garbage at the head of the bed. I wouldn't want my patient, to be smelling that the whole time. So I would actually switch and I'd put my table here and I'd put my garbage at the end. So just, make that consideration based on the room that you're changing. Okay. So I always like to rip the corners and fold this bag over. It helps me out, again, sets me up for success. So that when I'm dropping stuff into the garbage bag, it stays open and it's not going all over the floor. Okay, again, we don't want to track through that. You can use, like I said, the garbage can. So I'll just go ahead and tape that here. Okay, and you can see it's nice because it's nice and high. All right. So the first thing we want to do is put on a pair of our non-sterile gloves or our clean gloves, and we're going to remove that outer dressing. We do this in stages. So inside of the wound there's a packing. On top of the wound there's 2 4x4s, and then there's an abdominal dressing. Right now, if I went to go open my tray first, my wound is considered unsterile. Okay, so I wouldn't want my sterile dressing and my unsterile wound, my sterile dressing tray open to my sort of unsterile wound. So we try to get it as sterile as possible without it actually being open to air for too long. So that's why we work in stages. So I'm going to actually just put on gloves and take off the outer dressing. Okay, so I'm going to gently pull the skin taut and I'm going to take the tape off. Okay. I'm going to remove the abdominal pad by putting it away from the patient's face. Unless the patient's interested and wants to see it, they generally don't want to see the type of drainage there is. From here, you need to assess every level of packing or dressing on the wound. So you have to assess it for the drainage, the type of drainage, if there's an odor, and the amount of drainage. So just to review the types, so there's serous, serosanguinous, sanguinous, and then purulent. Okay, so the type, if there's any odor, again, you don't have to go up and smell it closely. It's usually very obvious, okay? If there's an infection brewing, you'll be able to smell it as soon as you remove it. And then the amount. So some of the language at North Bay Regional when I was working there was scant, small, moderate, heavy, copious. You're just going to have to choose the option that best shows how much drainage is on this. So after it's done, you're just going to wrap it up and put it into the garbage, and you're going to remove your gloves. Okay, you don't want to leave your gloves on for a couple of reasons. So one, they could be heavily saturated in drainage, and then we're going to go ahead and open our dressing tray. Students like or think that they like to wear gloves while opening this, but it really gives you a false sense of security. Your hands aren't sterile, they're still clean, so they think that they can touch more than they should be. So I encourage you just to have clean hands when you're opening your sterile dressing tray. So right now all that's left on there is the 2 4x4s, which I'll take off after because I don't want it to be open to air for too long, and then the packing, so I'm just going to leave it as is for now. So now I'm going to go ahead and open my dressing tray, and I'm going to set this all up. So this is perforated, so I can just rip this easily. Okay. Remember, the dressing trays, you want to always open your first fold away from you. You can also see that I've kept it to the right-hand side of my table so that I have room for my supplies and I'm thinking ahead, I'm going to have room to open my sterile gloves at the end of the table. So I'm going to go ahead and open the first fold. Remember, you can touch the outer 1-inch border. Don't forget about your blue transfer forceps, okay? I see a lot of students during this want to do this and then pull their drape down with the blue transfer forceps. Again, remember rules of sterility. Anything that drops below the table is considered unsterile. So if you do this and then you set up the rest of your tray using these, you've set up an unsterile field. Okay, so you need to make sure you grab these. I always encourage you to stabilize it in the middle of your tray and then use your hand, okay, to drop that drape down. From here, I'm just going to get this out of the way, okay, and I'm going to add some of my supplies. There's an extra garbage bag in here that we don't use. You can just toss it. Okay, remember, because now I've touched the ends of the blue transfer forceps, they have to go into the outer 1-inch border and the tips need to remain sterile. Okay, so I'm going to go ahead and add my sterile supplies. I discourage students from opening it over their tray. Sometimes the packaging can hit your tray. Okay, so you always want to open or banana peel your product open. Okay, and then I use my blue transfer forceps to guide it onto my tray. If you are somebody who likes to open your products and drop them, that's fine. If you have the control to do so, I'm okay with that. But I find it challenging to open and sometimes they bounce. And if you're in a room by yourself and you don't have somebody to help you or go run and grab you extra supplies, it can be very challenging. Okay. Okay, I'm going to add my conform. We simulate sterile scissors, so I'm not going to banana peel it, but you would, and then you could grab them with your blue transfer forceps. But for today, I'm just going to drop them, okay, on my tray. Okay, so I have everything on my tray that I need. The only other thing I need is my saline. So I'm just going to get this stuff out of the way so I can go ahead and pour it in. Okay, if there's a sterile cap or seal on your container, you're going to peel it and you can pour it right into your tray. If it's a multi-use container that's already been used previously, you have to do what's called lipping. It's removing essentially the first top layer of the fluid. Okay, so you're going to pour out the first little bit and then you can go ahead and pour it into your tray. Okay. Alright, so from here what's left, I always like to do a double check before I get ahead of myself. I have my measuring tool, second pair of gloves I'm about to put on, my sterile gloves and my tape. Everything else has been added sterilely. Remember, once we go sterile, we're not going to be able to touch anything outside of our tray. So I always like to take a breather here and I like to double check. So now that my tray is set up, the last thing I need to do is put on my the last thing for these blue transfer forceps. I'm going to put my gloves on, okay, because the blue transfer forceps has already set up the tray. So the last job is to remove the final packing so that the wound is exposed before we go sterile, okay? I wear gloves because, again, I could be coming into contact with bodily fluids. Okay, so I'm going to use my blue transfer forceps to remove the 4x4s. And again, I'm going to assess this layer for the type, amount, and odor of the drainage. Okay, and those go into the garbage. From here, I need to remove the inner packing. In this simulator, it's going to remove very easily, but depending on the frequency of your dressing, a saline soaked dressing could go in, and over days, if it's every 2 or 3 days, it could dry up, so it adheres to the tissues. So as you're removing it, just be mindful. If it's sticking to the tissues, it can be very painful for your patient. Sometimes the wound care clinician or the physician will encourage you to, remove a little bit of tissue as you're removing it. It's called a natural debridement, and it's actually healthy for the wound because then it takes off that old dead skin and it's producing new healthy skin. But if it's really painful for the patient, sometimes nurses have also instilled a little bit of saline. We try to discourage that because now we're putting microorganisms or bacteria back into the base of the wound. I know we're about to clean it, and that's why sometimes we will do it. But again, you're going to have to consult with the team, see what's best for your patient, and then move from there, okay? So I'm going to remove the inner packing, okay? Again, I'm assessing for type, odor, and amount, okay? And then all of this can go into the garbage, including your gloves, okay? And here I'm going to wash my hands. So you can eyeball your wound now, but we're not going to do the true assessment until it's clean. It's amazing how different a wound can look before it's cleaned. So you don't want to have your assessment be off. But I am just eyeballing it. Okay, it does look fairly good. I know it's 100% red. I don't see any discoloration. There's nothing significant with the peri wound from what I can see. Okay, so far so good. So now it's time to go sterile. So I have to put on my sterile gloves so I can play in my tray. Okay, if you or somebody that opened your tray in the middle of your overbed table and you didn't have enough room, you could go ahead and use the bed to do so, just making sure you're adhering to the rules of sterility. But because I thought ahead and I moved it to the right hand side, I like to come to the very edge of my table so that I'm not impeding on my sterile tray. Okay, so make sure you're opening, okay, using the two flaps, that you're not touching the inside of your sterile gloves. I'm going to don my dominant hand first, okay, touching the outer cuff, making sure not to touch the outside of the glove. Now I'm going to go underneath the cuff, so I'm touching sterile to sterile, okay. And now as soon as my hand hits that, I need to get that film out of the way so that I don't contaminate that glove, okay? You can see that the cuff of the right glove, it's cuffed on the right glove. I'm not going to go ahead and fuss with that. I'm doing a dressing with my hands, not my wrists. So the risk of contaminating my gloves will be higher if I'm playing with those. So just leave it as is, okay? I'm going to extend my sterile field, okay, to here. So I can actually go in my tray and grab it. Remember, while you're opening it, I see a lot of students dropping it down. Try to do it over top so you maintain sterility. Okay, because our hands are sterile, we can touch all over the drape. Okay, you want to take a backhand approach. Okay, and you want to wrap your hands as you're dropping it. Okay, what we want to avoid is contaminating your gloves while dropping the drape. So I don't want you to do this and drop it. Okay, sometimes your gloves can hit the patient and hit the bed itself. That's why I want you to try to curve your hands, okay? Making sure that it's not hitting your wrists or your forearms, and you're just gonna drop it and hands up, okay? From here, now I can get everything ready. So if there was a heavy amount of drainage, I would need so many more 2x2s to clean, but because this is a simulator for demo purposes, I know that I need 5. So, okay, so the order in which we clean a wound is always the base, working our way out, okay? Because the base of the wound is considered the most sterile, and you want to clean from cleanest to dirtiest. We don't want to go from dirtiest to cleanest. So I'm actually going to go down the center of the wound, inside on the side, inside on the side, and then finish with the peri wound for a total of 5. Let's say if the middle was, really full of drainage, I would stay in that area using 20 2x2s if I needed to make sure that that area was cleaned before I move on to the next one. So you don't want to go and clean everything and then start again and then start again. You need to stay in one area and clean and then move on from there, okay? So again, because I'm sterile, I can use my hands. You guys are probably used to doing this in first year where you were doing the no-touch technique where you had to wring it out, okay? But again, because we're sterile, we don't have to do that. So that's the nice part. So I'll get my 5 2x2s ready, or however many you would require. Remember to try not, you have to contain the water. If you get a part of your sterile drape wet, it's considered like a contaminated area or unsterile, so you have to avoid that area. Okay. from here, I'm going to take my forceps and again create a little cushion so you're not dragging the tip of the forceps down against the skin. I'm going to work in a head to toe, and I'm going to go down the base of the wound, okay? And then I'm going to throw it in the garbage. Okay, again, my elbows are up, my hands are up, and I'm maintaining sterility. From here, I'm going to go inside on the side. I'm going to go on the opposite side now. I'm going to go along the peri wound. And I'm going to go on the other side of the peri wound. Okay? So, I mean, that was very straightforward and very easy. I can tell you that it's never that easy. But we're going to, for demo purposes, we're going to move forward. So, I'm about to put a saline-soaked dressing inside of the wound, so you don't have to dry it. The area that we do have to dry, however, is the peri wound. If you don't dry the peri wound, it could cause what's called maceration. So it's like a pruning or a whitening of the skin because moisture is sitting on top. We don't want that. It's going to affect skin integrity and you know, maybe further break down the wound. So I'm going to go ahead and I'm going to dry, okay, the peri wound on each side using a new 2x2. Okay. So from here, before I redress the wound, don't want to get ahead of myself, I need to assess, okay? So we're going to assess the wound for its color, okay? So this is what would be called like 100% beefy red wound. Sometimes it'll ask you to do a percentage of the different colors in a wound. So if there's necrosis or it's black, brown, sloughing, which could be like a yellowish kind of peeling type of the skin, and then redness. So you usually have to use 100% break down those colors. This is 100% red. The other thing is the peri wound. So there's slight redness. You guys probably can't see it on camera, but it's called erythema, and it doesn't extend, you know, past 1/2 centimeter. So I'm not worried about infection here. There was no purulent drainage. There was no foul odor. The wound looks good, and the peri wound looks like it's, you know, good. So for REEDA, so redness, you know, erythema doesn't extend past that. Edema, there is no, you know, there's going to be some slight swelling because the wound is healing, hopefully, but there's nothing that I'm concerned about. The other E for REEDA is ecchymosis. So is there any bruising present along the peri wound? There isn't. The D is drainage. We already did that in every layer, so type and amount. And then A for REEDA is approximation. So this wound is not well approximated. The edges, okay, are not touching, and it's in a V. However, it's fairly regular. So I would assume as long as the dressing changes and the healing process goes good, the wound base is going to start to heal, and then those edges are going to come nice together. You'll see not all wounds are regular. So if they're irregular, the base, you're going to clean from the center and just slowly work your way out. I essentially treat a wound, I kind of draw a line down the center, and I treat it like 2 separate sides, cleaning as I go, okay? So that assessment is done. I also need to do length, width, and depth. So I'm going to grab a cotton tip applicator, okay? My hand is sterile, and inside of this package is sterile, so if you need to, you can move this over to make sure that your measuring guide is accessible. So from here, let's do length. Again, don't contaminate your hands. I'm just going to hover over the wound and do an approximate, okay, measurement. So this is length, okay? So it's 14 centimeters in length. You're going to go to the widest part of a wound. Again, if it's irregular, choose the widest part. Okay, and I'm going to hover over. Okay. So 3 centimeters wide, and I'm going to go to the deepest part of the wound, bring my fingers to the edges, and again, it looks like it's roughly about 3 centimeters, and it is. So 14 times 3 times 3, okay? I'm going to throw this one in the garbage. I'm going to get another one. And I'm going to go along the borders, checking for undermining, which is that shelving. Okay, it starts to develop a little bit of like a shelf underneath the top of the skin. So not always visible until you bring your cotton tip applicator. All of a sudden, it goes in a little bit more because it can be hard to visualize, especially depending on what side you're standing on. Okay, so I don't detect any undermining here. And then as you're going around, sometimes your cotton tip applicator will actually slip into a physical tunnel. If that happens, we like to indicate where the undermining and the tunneling are based on a 12-hour clock, in my experience. So the top of the patient, or the top of the wound, would be 12, and then I would indicate. So let's say I found a tunnel here, I would say approximately at 5 o'clock. We will put a cotton tip applicator in. We'll try to get a measurement. We do have to irrigate, so with saline, so we'll get a little bit of like a syringe, and we'll irrigate that tunnel, making sure that there's nothing stuck and it's flushed out. And then we'll actually pack the tunnel first. Okay, it's a little bit of like a packing ribbon. It's not the conform. Conform would be too tight against that skin. So we would use a different product. We would use a cotton tip applicator to help feed that ribbon in. We would cut it at the level of the wound, and then we would consider or continue packing with the conform the rest of the wound up. So there would be 2 products in there. Okay. But there are none, so that's great. The wound actually looks like it's improving, so we tend to note if it's improving, it's about the same, or if it's deteriorating, and it looks like it's improving from the last nursing note that I read. Okay, and I'd throw that out. So now I'm ready to wet the conform. Okay, so I just wet the whole roll. I know I'm not going to use the whole thing, but I don't want to. You can't piecemeal your dressing in there, other than the ribbon and the conform. If I had to do that, that's 2 products, but you really don't want to do pieces, okay, of conform. You want it to be one consistent piece. You also don't want it to be soaking wet. It just needs to be damp, so you're going to wring out any excess fluid. This technique can be a little challenging. Okay, I'm going to tell you right now that it's more challenging on this mannequin than it is a person, because this is like plastic and it can be hard to actually pack and stay in place. But the actual technique is you want it to be compact in there, but not so tight. If you put it so tight, it's going to start pushing on the borders of the wound, and it could actually alter the the shape or the size of the wound and start to affect skin integrity. So you want it to be firmly packed, but loose and fluffy, if that makes sense. Okay. I also like to hold the actual roll in my non-dominant hand, and using the tweezers, I feed it into the wound. Okay. We want to try to avoid as much as possible touching the peri-wound or the skin before going into the base of the wound, because that part's the most sterile. Okay, you'll see at the end once I cut it, it's challenging. There might be a small piece that touches it. However, we want to try to avoid that as much as possible. Okay, so I'm just going to start feeding this into the wound, okay, in small little layers. Okay, it can be more than 1 layer, but you're starting at the base, working in a head to toe fashion, making sure that every edge of skin that's exposed is covered by the saline soaked dressing. Okay, I'm going to work my way back. I'm just going to hold this here for a second. So you can see a small piece touching the edge, but that's okay. Okay, so I would want to make sure that I pack to the very top or the edge of the wound. I don't want saline soaked dressing to be sitting on that peri-wound. Again, we're going to cause maceration. So light, fluffy, compact, and just to the level of the wound. Okay, from here, I'm going to cover it with 2 4x4s. And then I'm going to finish with the abdominal pad. Okay, I can remove my gloves at this point because the sterile part is done. And I find it very challenging to try to tape with gloves on. And for a wound, we do like a window pane where we do all 4 edges, okay, to secure it in place. Okay, throughout I would have been assessing my patient's nonverbal and verbal cues of pain, because that's something you should be noting in your nursing note. Okay, I'm going to make sure my patient is covered, okay, and comfortable. Everything can go into the garbage except for the silver utensils. So these would go into like an autoclave bin in your soiled utility at the hospital, and these actually have to go into the sharps container. Okay. And everything else is just going to go into the garbage. Again, if your garbage that's in the room is full of drainage and dressing supplies, please make sure you're changing the full garbage. Otherwise, you're just going to take everything out of the room. Okay, clean your table again. Now lower the patient down, making sure that the two side rails are up and that they have their call bell in place, making sure that they're comfortable. They don't need anything else before I leave the room. I'd probably want to get out there and write my measurements down and my assessments before I forget, if I'm documenting at a later time. Okay, I'm going to wash my hands, and then I'm going to bring all of this outside of the room, discard, and then document.